Today we're going to perform a procedure where we reposition fat on the lower lid, a form of blepharoplasty where fat is preserved. We're also going to graft some fat to areas around the lower lid to efface the remaining periorbital hollows. She'll also have some skin excised and also a canthal suspension. This will probably be a commissure sparing open canthoplasty from the lateral canthus, and I'll explain that during surgery. So the goal of this procedure is to use her own native fat from the lower lids here and here and use that to efface this hollow. Now, transposing fat on the outer part of the eyelid for these hollows I find is not successful. I have taken the fat here, cut it up into small pieces and implanted there, or you can graft in this area. The issue with fat grafting in the lower lids is to be careful so that we don't end up with any contour irregularities. And then we'll suspend her lid and remove a little extra skin. So on this patient, we're going to harvest some fat for injection to the periorbital hollows. And the harvesting cannula I use is graded, kind of like a cheese grater. It has 1 millimeter ports in it. This one is made by Tulip. And this is what we'll use to harvest the fat. There's a lot of things you can do with fat after you harvest it in terms of processing it. Some people mix it with certain chemical agents. Some people spin it. My preference is to lay the fat on Telfa, drain it, then wash it, and then place it for injection. I've had really good success with this. There's not a lot of good evidence-based data that suggests that one harvesting technique is better than the other. After it's harvested, it'll then be injected into the recipient site with the injection cannulas, and there are two of them here. One is a 0.7 millimeter tip, which I use for around the eyes. One's a 0.9 millimeter tip, which I use for the face, and we'll show you how that works. All right, so we're going to start with harvesting fat. We're going to take it from the inner thigh, so I'll make an entry point here, and you have to get through the fascia. This is a 10 cc syringe. I like to do manual suction, not wall suction, because I think that there is less trauma to the fat cells. And then I will suction. I'm keeping a constant negative pressure. I'm pinching the fat in between the cannula. That puts pressure onto the cannula so the fat can be harvested nicely. I'm staying deep, but obviously above the muscle, so we don't create any divots. And you keep the negative pressure. And by squeezing the fat into the tip of the graded cannula, you can easily harvest fat. So you can use your hand here to create suction. I find this to be a nice site to get fat. Clearly the belly, because the patient's in the supine position, would be easy. But in her case, she had had a tummy tuck. As a result of that, it would be a little harder from the belly. I don't need a lot of fat because this is not pan-facial injections, just around the eye. So we're not going to get more than what we really need. It's a pretty fast process, not painful. If you're in the right plane, usually there's not much bruising and swelling. So what I'm going to take the fat, we're going to place it into a strainer. And we're just going to wash the fat. And we'll go to the other side. So we're just harvesting again on the other side, again pushing
with my fingers the fat into the grated tip of the cannula. There's a good amount in this area. And you can also lay it directly over the telephone, let it drain out. And then this can be washed afterwards also, but let it drain first. Either way is fine. I use my pinky to create the negative pressure. It's not necessary. Whatever method to create that is fine. I'm sure we have 7 or 8, don't we?
Yeah. You said you're not going to need that much, right?
Yeah, I'll go back and get one more and then I'll sew it together. So the fat's now been prepared. Looks like there's about 8, 9 cc's. We don't need much more than that in this case. It's going to be transferred into 1 cc syringes now for injection. So here's the 1 cc syringe. And now he's transferring it, and that's the method by which that it's done. As you can see, the incision site was small. We'll just put a few 6/0 plain gut sutures and it heals well. Usually not an issue. Theoretically, you can get a little darkening at the site. You can also enter more in the groin region and do it. And I'll put 2 or 3 little sutures here. Just tying the suture. I'll put 1 more little bite in afterwards. All right. Because we're doing transposition subperiosteally, I'm going to graft this outer groove first above the periosteum. And in the lower lid, the grafting should always be done perpendicular to the lid margin. If you go parallel, you can get sausaging. or these mounds of collected fat in this area. So let's go graft this area first. I'm going to transpose fat into this hollow, but this hollow, there wasn't fat to transpose, and when you do transpose from that area, it does not work well. This is the 0.7 millimeter tip. We're going to have an entry point somewhere here, and I'll graft perpendicular to this hollow. We can't give too much, because if we do, she can get contour irregularities. And the grafting should be multiple passes and very small amounts passed with each. My finger is here on the orbital rim, and I am giving deep, very, very small amounts, and I know exactly where I'm going. Very, very small amounts with each pass. So you can see I've probably done 30, 40 passes now, and only 0.1 cc was given. We have to be very careful in this area, because the problem is getting contour irregularities, and it comes from giving clumps of fat so the injections are deep. So far we've given about 0.3. I may not give more than 0.5 or 6 here. I find that this area is generally overgrafted. Again, very small amounts. I've outlined it, and I can feel the orbital rim here. So we gave about 0.8 there, which for me is adequate. And now we'll go to the other side. Again, keep it deep. This is very thin skin over bone here. Use your other finger to guide where the orbital rim is. Keep it deep. This is all about technique. I can actually feel the bone here. And again, I'm going perpendicular. If I were to inject parallel this way or this way, the incidence of getting sausaging would be higher. So my finger's on the rim. I am deep on bone. I'm using this finger. You can use your pinky to inject, and I'm going deep. I can feel it over the bone, giving multiple passes. And again, with all these passes, the amount of fat given is very small. So that's about 0.7. I'll do what I did on the other side. There we go. Okay, now I was also going to give a small amount into this triangle here, probably another cc on both sides, and we can enter from the same locations. We are going to reposition subperiosteally, but this area here, I'm going to go deep again, but this is thicker skin, so the incidence here of getting a complication, a lump or irregularity is less. Look how little is going with each pass. And again, I'm above the periosteum. You can't inject it subperiosteally. You can inject deep. And to elevate this nasal midface, the fat in that area, I'm just augmenting multiple passes, small amounts, multiple layers. And I'm not going to give much because she didn't really need it. An area which I feel is important is this right by the ala, piriform aperture area, Ristow's space, named after Bruno Ristow. This area is an area of bone loss, so if we augment there, it tends to not give a nice transition to the midface, elevate it just a bit. Turning my wrist, going in all directions. Okay, one more and we'll go to the other side. Okay, and now complete it on this side. Same thing. It's also nice to do fat grafting at the beginning of the case because really surgery does wear you out a bit at times, even though if you do a lot of it, and you're a little more alert at this time. Sometimes I put sutures in these openings depending on how they look. It's not always necessary. It's probably fine not to. Okay, so the grafting's been done. Now we'll do the surgical part. This is this technique we talked about in the previous video. It's called the GRED, Globe Retropulsion Eyelid Depression Maneuver. I'm depressing the lid with one finger, pressing on the globe, exposing the conjunctiva. This balloons the conjunctiva forward. And if we're in the right plane, fat will expose itself 82% of the time. You can see the fat here coming forward, so we're in the right space. This is a 4-0 silk traction suture. I grab the conjunctiva and the retractors, which is this white tissue that you see here, and I feed. And can I have a hemostat? You want to put this on stretch. That's why it's an important hint to have a good towel drape that's nice and snug. If it's not snug, then the hemostat won't hold. Well, now in the retroseptal plane, go down to the orbital rim. I can feel this on the arcus marginalis. I'll put a DeMar insulated coated retractor in here. I will increase the length of the incision to the caruncle. And then laterally, we're going to take out a little bit of lateral fat on her. And you can hold this on bone. And now you're able to see the nasal fat pad, the oblique muscle, which is here, and the central fat pad. Nasal, oblique, central. This runs over this muscle, and that's why you don't see a separation of the fat pads clinically in patients between nasal and central. But the arcuate expansion, which separates the central and lateral, runs very superficial, and that's why it tends to separate the fat pads. So now we're going to make a pedicle over here. So we'll cut all the soft connective tissue attachments. You want to keep this vascularized at its base. It does tend to bleed sometimes. And when it does, you just cauterize. You just don't overdo it. And you want to separate it from the oblique, which is what I'm doing here. Just the little connective tissue attachments from the oblique muscle. And you'll break all these connective tissue attachments to the orbital rim. What you've done is created a pedicle here. So here's your pedicle. This is the implant we'll use to fill the trough. There's the oblique on this side. Now we're going to move this to the center. The assistant will pull this flap over with a pickup only, so that usually the tip will be pulled towards the assistant. It'll be pulled. Yeah. And then this pad will now be identified. Now you can see that it's pretty close to overlying the oblique, so I got to be careful here. So here is this pedicle. So now you can see very nicely the oblique muscle. Let's separate these little attachments here. One fat pad, the other, and the oblique muscle. Now, the assistant will let go of the fat pad, and when you pull these, if you look under the muscle, they freely move. It's like, see how the muscle look like shining a shoe underneath? Now, is that critical to do that? Probably not. Diplopia is unusual here. But when it moves, you want it to move freely underneath. And that's the pedicle you use to reposition. So now, with this being held back, we can go down to the rim and expose the rim. This lid's a little tight. You can see in here, on top of my Q-tip is the arcus marginalis periosteum. This is the fat pad, the oblique, fat pad, arcus marginalis periosteum. And this is the arcus marginalis periosteum. The yellow here is the SUF fat. I'm going to cut down to the periosteum here. Very tight lid. So now we're going to elevate the periosteum. I'm going in a subperiosteal plane around the infraorbital nerve. And this sometimes tends to bleed. That's okay. And you can actually, in this example, we will be able to see the nerve pretty well. So if there's bleeding when this is being done, all you do is you can tumesce it with a little bit of local. Put some pressure on it, and that's the best way to stop the bleeding, because in a tight lid to go in and try to cauterize is an extremely difficult task. And we dissect around the infraorbital neurovascular bundle. I'll leave the Q-tip in because it acts as a stent for the plane that I have to be in. We're in a very closed space here, so operating with people that you're accustomed to makes a big difference here. You can let go of the fat now. So now we'll take this fat. This surgery is all about precision and being able to do it in a very rapid sequence. What I find the biggest problem people have is a newness to it each time. It's not that kind of surgery. This requires someone with experience and a staff that's experienced. I would say that if you're going to do this with people that are not used to doing it, you can have a lot of frustration, end up with some issues, because if you start to bleed or if the view's a little obscured, people that have done a lot kind of know how to get around it. Okay, we just pulled the suture out. And you'll see when I tie it, the volumetric effect. I'll show you some little maneuvers we can do that pick that up for us. Watch now that it's flat, then I pull, how it volumizes and pulls up the midface. Before and is. You can see the volumetric effect. We're going to tie this. What the assistant's going to do is make sure that her instrument is wide open, not pinched together even a little bit. She's going to leave it wide open, push down to get the knot, then clip the knot, then pull up. And the reason she's pulling up is, if you don't, you'll get tied on the telfa. The telfa is there just to help protect the skin from darkening, color change, maceration, anything that can irritate the skin. Can I have the big scissors now? Here we go. We'll cut this down a little bit. Usually when I do this, I'll put 3M breathable foam tape at the end of the case. It reduces some bruising and some swelling. I don't do it all the time, but I do it sometimes. Wet one. So you can see she has a cheek mound, because the midface has been elevated a bit. And we volumized this area. Now what does this look like? If I put the Damar in now, you can see fat, oblique muscle, and fat. These are going into that tear trough. So this is the temporal fat pad being excised. This fat pad can also be repositioned, but when doing so, take caution, as I have found the incidence of double vision when repositioning this fat pad to be higher. So this area was repositioned, this area was grafted, and there was fat reduction performed. And you'll see we're going to most likely suspend the lid a little bit, and you can see when the lid is pulled and suspended that there's effacement of that hollow. It's exoplane. Again, I close the conjunctiva in these cases. Inverted buried suture. And the reason is, on straightforward transconjunctival blepharoplasty, I don't, but when I reposition fat, I do, only because I think that there's more inflammation in this case, and there's a higher incidence of issues with the conjunctival apposition, although rare. It tends to look hollow when she's lying down. When she sits up, that won't look that way after you do the repositioning procedure. As long as you repositioned appropriately, you can certainly take fat out of the orbit and hollow it with repositioning too if you overstretch the pedicle or resect too much fat when you're doing it. I tend not to resect fat when I'm repositioning. I transpose all of it. Some people do graded resections. We'll do this canthal suspension on her, but just support suspension. I'm going to showed you already how it's done from the upper lid in a closed fashion. I'm going to show you what's called a commissure sparing procedure, where the commissure is left intact, but a canthotomy is made. So it's open because a canthotomy is made, but the commissure is spared. And when you spare the commissure, there's less distortion of anatomy. So we'll leave the commissure intact and make an incision maybe here and do all our work through there. And dissect down to the orbital rim. I want to make this a small dissection. I can increase this a little bit. Sometimes there's a yellow fat pad from the upper lid that you can see here, and that fat pad is the temporal fat pad of the upper lid that prolapses laterally. And sometimes there's a fat pad that's present in the canthus named after a man named Eisler, and that can also be present. I'm going to just score that canthal tendon. I don't want to move it too much. I just want to give her support. So I'm not going to release it too much, but the inferior crust of the canthal tendon can be lysed here, but I don't want to release this too much. So I've released the canthus, but not overly, because I don't want to change her canthal position. So what I'm going to do here is expose the inner orbital rim periosteum, which is there, and then put the suture through. And that will be the anchoring bite. And then we'll go to and fro through the commissure. If you want to shorten the lid, you can open the commissure, or you can take a little bit of tarsus from here. Now we'll take another bite. The assistant's going to follow me by just giving a little down here, because this suture tends to ravel, and when it ravels on you, it's hard to get a good view of what you're doing. And I got another bite there. And now if you take a Q-tip and lift this, okay, like that. So this lid, if you lift on it, look at the displacement. You can see the distraction's probably 15 millimeters. On this side, it barely moves. And I haven't shortened the lid, I haven't distorted the architecture. All I've done is re-secured it. So that is a closed canthal suspension is when this is closed. You can make an incision from the upper lid, for instance. An open canthal suspension is where canthotomy is performed, but the commissure was left intact here, which is less disruptive than traditional open surgery. And that was the purpose of this procedure. So I'm going to put a bite. This is a plus minus through the periosteum here. Get a fixed bite. The assistant will hold the suture on this end so that I have a view of the field. And then just to give a little more support to the lid, and she'll let go. See how that ravels up? Just makes a big... And sometimes I'll take this out if I think it creates a deformity. And that just supports the orbicularis a little bit more. And if there's any pucker, which there's very little here, you can just undermine the skin here, and that'll get rid of any pucker. Okay, can I have the 6/0 nylon suture now? So she's been tightened, she's been repositioned, volumized. Because the commissure is intact, we don't have to reform the commissure, which is a really positive thing, because that tends to be one area of concern. When you disarticulate a canthus, you tend to have to reform that, and patients get bothered by the appearance of that when it's reformed. Here, all we have to do is suture the canthotomy together. If you don't have to reform the angle of the lid, that's a benefit, because that tends to sometimes lead to deformities. Notice how I'm pulling in this direction to make a incision perfectly straight so every bite is perpendicular. I would tell you that the stuff you do inside is the complicated stuff, but the stuff you do outside is what the patient sees, and you want to focus on what the patient sees. So far, I would say this has been, from the patient's perspective, minimally altering, because we haven't made any significant skin incisions, we haven't disarticulated or delaminated the lid. I'd say delaminated. In doing a transcutaneous procedure, we can pinch some skin now or create a little skin flap if we want to. We'll take a look. If these canthal incisions, these open ones, are placed in the right location, these heal in a natural crease and they're just fine. The most important bite's right at the corner, and hers looks Okay, let's see again here. Yeah, okay, give you this. Now, can we remove any skin? If we open her mouth, we can see that maybe there's a few millimeters. The assistant rolls the eye up at all times, and when your assistant works with you, it's a rolling motion, not a pushing motion. And I think we could remove a little skin for her. And it's got to be all the way to the corner because the rolling has to be way at the corner here so that we can see the corner when we do the work. So let's do a little infraciliary mark here. And can I have some local anesthetic? There's two ways to do this. You could just do a pinch, as classically described by Frank Kamer. If you use white ace, hyaluronidase, it's a little sticky, maybe easier. Or you can create a little skin flap. Prefer the skin flaps. The reason is when you do a skin flap and you put it back down, there's some inflammation that occurs and some, I think, contraction of the skin, so it may actually change the quality of the skin a little bit when it heals. Whether that's true or not, I can't tell you for sure. Just a feeling I've had from experience. 15 blade. We'll make our incision now. The lid has been tightened. There's going to be a little bit of bleeding. I will stop all that. Now, this is probably something that most people prefer to do with the scissors. As long as you're pulling down with your finger here. So because she only has a few millimeters to remove, we'll just do that. Most of the bleeding that occurs here occurs from the wound edge on the skin, and there's little things we can do to help there. I don't like to cauterize too much under the lashes. I don't want to lose lashes, but what you can do when you're bleeding from right under the lash line is balloon a little bit with some anesthetic. Again, the tumescent effect of that may help. I left a little wisp of skin here. Okay, can I have the 6-0 plane? And I'm just going to tie here. We use 6-0 plane. This absorbs. I don't take it out. I suppose you can use 6-0 fast too. It may not have as much tensile strength. So again, we transposed fat nasally for volume. We grafted or transferred fat laterally for volume. We performed a canthal suspension sparing the commissure. And then we removed some skin. So we addressed the anterior lamella, we addressed the canthus, and we addressed the fat. And this was not a transcutaneous procedure. As I've said before, I looked at over 1,000 cases, and the incidence of complaints of increased wrinkles was 2.2%. Similar to transcutaneous surgery, but without the risk profile of transcutaneous surgery. And in my estimation, for what I do, and again, I do oculoplastics, lower eyelid malposition, retraction is the worst complication I can get. Someone can always have a laser for wrinkles, can always have a filler for little hollows, but when you have lower lid retraction, we're talking pretty significant surgery, very expensive surgery, a lot of downtime, and that's something that, in my estimation, we want to avoid at all costs. Put a little intermarginal tarsorrhaphy suture in the end. She's going to heal well. Let's do the transconjunctival repositioning on this side now. When you inject the lower lid, bend the needle away from the eye. You can depress the globe. It's white, so you can see it's injected. Additionally, we did not put corneal protective lenses in the eye. I'm going to put it in the eye. When you do the canthal suspension, always take it out. So I'll show you one eye did without it, one eye will. It's probably smart to use it at all times. I actually trained without it, so being accustomed not to using it, but I think if anything were to happen, the liability will be high, so my recommendation is use it at all times. So, depress the lid, press, you can see when I push down here, the tarsus ends here, the fat is here. This is all conjon retractors. As I said, in the study, we found that if you make your incision at about 6.5 millimeters, you'll enter fat 82% of the time. You can see the fat here. Perfect example of what we call the GRED, globe retropulsion eyelid depression, 2 fingers of one hand only. That way you don't clutter the field with lid plates and retractors, etc. I just find it to be easier. This suture for retraction has to grab the retractors. We're going to do a lower lid retraction case next, and we're going to dissect the retractors off the conjunctiva, and you'll see a really good example of the retractors. This has to be fixed to something now, and then I will dissect down to the orbital rim. We'll put the Damar in. There's the oblique, as you can see. So I'm showing you the nasal fat pad. The oblique is there. This is still the septum. Oblique and 2 fat pads. See how the fat overrides the oblique here. So let's make our pedicle here. So to do that, we'll move this nasal and get some. I want to underscore the importance of the assistant. The assistant I have with me today has done many of these with me, and it makes my life easy because I'm more dependent on the assistant in this case than I am on in most cases. So she knows when to dab, when to show me exposure. And that's an important part of the surgery. Okay, so there's a pedicle here. And now we will move this in this direction. Pedicle number 2, and you can see how this moves underneath the muscle freely on both sides. So here's our 2 pedicles for here. Now we'll do the same thing. The assistant's going to roll the fat out of the way so I can expose the orbital rim, and you can see it here. So here's fat, and you can see that right above my Q-tip is the arcus marginalis periosteum. And we're going to take a Ragnell. This white band above my Q-tip is the arcus marginalis periosteum. Above my Q-tip there's the SUF, and there's the nasal lip elevators, the levator labii superioris and aliquae nasi. Now we're going to cut down to periosteum on this side. You can see the incision to periosteum. We'll use the caudal elevator. This is a subperiosteal dissection. And right on this side of me here is the nerve. And here's the dissection down to the side of the nose. And now I'll dissect on the other side of it. And there's our dissection. Now, I'll take a little local because there is a little bleeding again. Okay, so one fat pedicle will be lassoed. The farther down you lasso it, the more tension you'll have on it, the more chance of necrosis. The closer you hold it to its tip, the less tension, the more chance it will retract. So you have to find a happy medium. And I'm just lassoing it in many ways, forming a pedicle. And you can see now that this is your implant that will be used to reposition. Do the same thing we did on the other side. Again, when we tie this, the assistant will open the instrument, push down to clamp the suture, and then pull up on the suture. Once, there we go. So open, push down, and now pull up. And the reason for the pulling up is so that it won't, when you're pushing down, it's easy to trap more of the telfa. Awesome. And you can see the volumetric effect we've had here. And the Demar retractor. So this is a fat pedicle. This is the oblique muscle, and that's fat. We may have to trim that down just a little. Hold that. As long as you're not getting the base of the pedicle and you have some redundancy, you can take it out. Good. So this is the temporal fat pad being cauterized, and as stated, it can be repositioned, but in my experience with a higher incidence of double vision. See how this looks. When we do the canthal suspension, we can't have this in the eye because it affects the tension of the lid. We'll sew the conjunctiva together and then do the suspension on this side, take a little skin, and that will be it. And she will have had it done. Use the needle to engage the conjunctiva here. I'm using the needle as a traction suture. Okay. .15 blade. So as before, we're going to leave 3 millimeters commissure intact and then perform a canthotomy. When you perform a canthotomy, pull on both sides. If you pull on one side or the other, it'll distract your incision inferiorly or superiorly, which you don't want to do. And then we're going to cut down again to the canthus. And again, you can completely lyse the canthal tendon internally, or you can just score it. In her case, I don't want to move canthal position too much, so I'm just going to score it, not completely disarticulate it. Can I have a little local? When you're in these small incisions, sometimes it's very difficult to cauterize here, but it's very easy to inject. And the tumescence from the injection, just that effect, will help stop the bleeding. When I'm putting this suture through the midface, I'm holding the suture at the end of the arc because I got to really turn my wrist to get it out here. But when I put this suture in, I'm holding it in the middle because it's a little flick. I don't need all that exposure. Sometimes around the eyelid, you just get a little oozing. You got to go with it. You want to put these bites through the same hole in the commissure on both sides. And we'll tie this. So on this side there was a little bleeding, but I'm actually glad that happened because it shows you that if you just got to know where you are in general. Good tension, physiologic tension. My partner, Ray Douglas, uses the word physiologic tension. I like that. And again, I want to show you the commissure, the angle is intact. You don't have to reform it. This is really important. When this is intact, you don't have to reform it. That's a lot less headaches for a cosmetic patient. For a patient having a reconstructive procedure of the lower lid, such as a repair of an entropion or ectropion, if there's some deficits that occur afterwards in that area, that's fine. But when you're doing something cosmetic, they're not very accepting of these things. And of all the things we do, of all the revision cases I see, I can tell you that revisions of the canthus are some of the hardest to get right. I think only about 40% of patients are happy when the canthus has to be revised. So a word to the wise, keep it simple here. Okay? And all I did was plicate her orbicularis here for a little more support. There may be a little puckering phenomenon. I'll correct that right now by undermining the skin as we did on the other side. I'll trim these PDS sutures. And then we'll close this 6/0 nylon. I'm pulling, making sure that every bite is perpendicular. What they will see is this repair on the skin. They won't see anything under the skin where all the tough work was done.
So this is the remaining closure of the canthus. I use interrupted bites here. I like to evert the wound edges. I don't put in too many bites because there tends to be an egress of blood from this area at times. I like to allow that to happen so that it doesn't build up under the skin. Again, pay attention as much as you can to meticulous closure so this looks appropriate after surgery.
Okay. See how natural that looks? Pretty good. Maybe one more bite. Also, when you take sutures out, when you don't have to take sutures out of the gray line, when you don't have to reform the gray line, it's a lot more comfortable for patients too. These sutures don't hurt to take out. The gray line sutures that form the angle sometimes do. You want to keep this a few millimeters below the lashes. If you hit the lash line with this, you'll end up losing lashes. And this really does heal very well. Again, trying to hydrodissect the skin from the muscle. And we'll let this work for a minute here. It's recently been shown that motor innervation, movement in support of the lower lid, from a motor perspective, is from the zygomatic and buccal branches of the facial nerve. We used to think that they would send vertical twigs to the lid, so when you were doing dissection here, you can denervate the lid. It's now been shown out of Asia in a beautiful cadaver study that the nerves actually coalesce and come up this nasojugal groove area, and then they supply the lid this way, and then they supply the glabellar muscles, and there's a branch of the buccal that also does the procerus. So dissection in this area theoretically shouldn't harm the nerve. However, you can still get muscle trauma from it, and you can still get scar around muscle, so that's not completely protective. But from an innervational standpoint, we now know that the innervation's a little bit different. It's a recent publication in the literature. The bleeding here is from the inferior wound edge, not from just under the lashes. But from just under the lashes, again, you could kind of tumesce a little bit. And then on the inferior skin edge, you can do the same. And that way you don't have to worry about cautery so much. Open her mouth wide. And we'll just sew this together. I started with one little bite in the center. This will heal and it will be insignificant. You will not see this incision. Been doing this for a very long time, and this doesn't tend to create a problem for patients. All right. Last thing I'm going to do is put a bite from the upper to the lower lid. The only reason for this is when she opens her eyes, it'll pull the lower lid up. We leave it in for a week. This can be a little claustrophobic. If it bothers them, we take it out early. It's a gray line stitch. Just a little more support. She's had a transconjunctival incision. The retractors have been lysed. So if during this first week the upper lid opens, she opens her eye, it'll pull the lower lid up. It's just another protection against retraction. If you look at the curvature and contour of her lower lid, no hollows. We saw her preoperative picture. Looks much better. I'm pretty satisfied with what we've done here. Let's put it on the other side.